Alright guys, let's get busy talking about our ovarian cysts. We're going to have 3 types of ovarian cysts to talk about, and then towards the end we are going to talk about a couple of complications of ovarian cysts. So let's go ahead and get started by talking about our follicular cysts. And follicular cysts are going to happen when we have development of the Graafian follicle that kind of goes awry. So we know that during normal menstrual cycles we have our immature egg, and as it matures through this cycle over approximately 14 or 15 days, it produces estrogen, it produces some zona pellucida in the form of fluid, and then around day 14 we have this egg that pops out and is ready for ovulation. What can occur in our cysts is that we have failure of this rupture of this Graafian follicle, and instead fluid just continues to accumulate. So if we review this pathophysiology, it's going to be failure of our Graafian follicle to rupture, and I want to remind you guys that a predominant part of this Graafian follicle is going to be our granulosa cells, and these are going to be the cells that are going to be responsible for this cystic fluid accumulation. So you can imagine that you're going to have a large cyst, probably about this big in comparison, because we never get this rupture. And if we were to look at this on ultrasound, this cyst would look like this here on our ultrasound. And so if we zoom back out, we can talk about some of the associations of these follicular cysts. These follicular cysts are associated with an increased estrogen state, and this makes sense, right? Because along this journey, as the egg is growing up into the Graafian follicle, it is also promoting endometrial growth, right? So if we were to kind of trace endometrial growth, it would be low, and then it would start getting bigger and bigger and bigger and bigger and bigger as we had more and more estrogen produced. So it totally makes sense that if we look at our associations, an increased estrogen state is going to lead to endometrial hyperplasia. And this all ties into the pathophysiology of our follicular cysts. And so it's going to be the most common mass in our young females. And then another thing is that this is the pathophysiology of polycystic ovarian syndrome. And we know that in polycystic ovarian syndrome, we're going to expect a patient that presents with a classic syndrome of obesity, acanthosis nigricans, acne, and hirsutism. And this is all due to the hormonal imbalance where we have excess of estrogen and we are not making it to this corpus luteum stage where we expect progesterone. Let's contrast this now to our theca lutein cysts. So you will remember that I mentioned that our Graafian follicle is composed largely of granulosa cells. However, we also have theca interna cells. And so if we were to zoom in here to our ovary, we would see that our granulosa cells would be a cuboidal epithelium here more towards the center, whereas our theca interna cells are going to be a squamous type cell out here on the periphery. However, they are also capable of producing fluid. And so essentially these are both going to be fluid heavy cystic structures, but the pathophysiology is a little different. So in our theca lutein cysts, it's going to be increased beta HCG, which we know is a hormone of pregnancy. It's going to lead to stimulation of these theca interna cells, and they're going to lead to bilateral cyst formation. It's important here, theca lutein cysts tend to have a predisposition to becoming bilateral. They tend to present that way more than a simple follicular cyst would. And if we look at the etiology here, it's going to be things where we have increased levels of beta HCG. So choriocarcinoma or molar pregnancy are both two pathologies where we have huge increases in beta HCG, and this is going to lead to our theca lutein cysts, and these should resolve after our beta HCG levels normalize. So I'm going to draw another circle here around this follicle, but this time in pink, and this is how a theca lutein cyst would appear. So if we were to look at it on our ovary, it would be this little pink circle here. These are both going to be fluid-filled cystic-like structures that you could visualize on ultrasound. Now let's contrast this to our next pathology, which is going to be our chocolate cysts. And chocolate cysts are different. Whereas previously we were talking about inherent ovarian problems, our chocolate cysts are going to be migration of endometriosis, which we know starts here in the uterus where I'm highlighting in brown, and essentially this uterine tissue is going to migrate out and it's going to land on our ovary. And so you can expect that we would have a cyst closer here to the periphery of the ovary that is just growing and growing and growing, and we call these chocolate cysts because they look like chocolate on gross exam specimen. And so if we review our pathophys here, this is endometriosis localized to the ovary, and we expect the woman to have underlying endometriosis that perhaps is not just located in the ovary. So in underlying endometriosis, We can expect a premenopausal female usually who's going to present with pelvic pain and dyschezia and perhaps dyspareunia. And this is all going to depend on where the endometrial tissue has landed. And so in some cases, let's say it's in an ovary, this is going to be a chocolate cyst. This would probably present with adnexal type pain because that's where the endometriosis migrated to. Let's move on now to talking about some of the complications of our cysts, the first being ovarian cyst rupture. So in terms of these really fluid heavy cysts that we talked about here in green and pink, these fluid collections up here are going to have the ability to burst open, and when they burst open it can be quite painful. And so this is going to present as lower quadrant abdominal pain, usually going to be unilateral if one cyst just bursts open on one side, and this can also be accompanied by bleeding. And so on an ultrasound you would expect to see a collection of fluid in the rectouterine pouch because that is where adnexal fluid drains to. Now you could also see blood here because when we have rupture of this follicular cyst or this thecalutean cyst, we can have exposure of blood vessels with that rupturing pathology, and they can bleed out a little before hemostasis is obtained. Now when it comes to the chocolate cysts, these can also rupture or be disturbed, but they're less likely to leak fluid, and I would say they're more likely to be leaking blood because they don't really have a lot of fluid. They are more of like extra uterine tissue. So the chocolate cysts tend to be a little more firm, whereas the follicular cysts and the thecalutean cysts tend to be more fluid composed. Now let's move on to talk about ovarian torsion, which is going to be a really high yield surgical emergency. So in ovarian torsion, what's happening is we have twisting of our ovary and our fallopian tube around the infundibulopelvic ligament or the ovarian ligament, and this is going to lead to compression of ovarian vessels. So let's go ahead and orient ourselves to some of this important anatomy here by zooming in and doing some labeling. So here I'm going to draw in our infundibulopelvic ligament here, which is also called the suspensory ligament, and this is going to carry blood supply from the aorta via the gonadal artery, and it's also going to carry lymphatic supply as well. And then if we label this structure here, this is going to be our ovarian ligament here, which is not that special. It doesn't really even contain blood supply or anything. It's just there providing support. And then here we have our fallopian tube, and then we can also draw in some collateral blood supply from our uterine artery, which is also going to help supply the ovary with blood. Now what happens here is we can get twisting all up in this area, and when this twisting occurs, we are essentially clamping down on a lot of vessel structures. So what happens if we clamp down on this structure here, the suspensory ligament? Essentially we are going to be cutting off blood supply right here and also cutting off return of lymphatic drainage. And so with the cutting off of blood supply, this can result in ischemia, and with the cutting off of the lymphatic drainage as well as our venous drainage, we're going to be unable to have return of that fluid, and so it's going to present with edema in the ovary. So we're getting two things happening here. We're getting lack of arterial blood flow, and then we're getting backup of edema back into the ovary. Luckily, we have some collateral from the uterine arteries, but these can sometimes also be tied up depending on how the ovary flips in space, and so it's not always guaranteed that we're going to have collateral blood flow. So this is always going to be a surgical emergency. We're super worried about this ovary not getting enough blood supply and dying and resulting in infertility or an acute abdomen. So if we zoom out, let's kind of review some of the things that are going on here. We're going to have venous as well as lymphatic compression here, which is going to lead to our edema, and then we can have arterial compression, which can lead to ischemia and necrosis. And we mentioned that the ovary does have dual blood supply from the ovarian and uterine arteries. However, we still are very concerned for necrosis and ischemia in this ovary, and this needs to be managed immediately and surgically. And this is going to present with acute onset unilateral abdominal pain. A classic vignette is going to be a patient who's outside shoveling snow and like lifting heavy things, and when they like grunt really hard, they're going to flip that ovary, and then all of a sudden they're going to get this increasing abdominal pain on a really acute timeline, and this is because their ovary is getting starved for blood. And now you might be asking me, Jake, I get it, this is going to be lower quadrant abdominal pain, but you said the same thing for our ovarian cyst rupture, and that is a fantastic point. And so what's going to help you determine whether it's this or that is going to be our ultrasound. So if we were to ultrasound an ovarian cyst rupture, we would probably see a cystic looking ovary, and we could see some cystic fluid or blood in the rectouterine pouch. However, if we were to get an ultrasound of ovarian torsion, if we were to put some Doppler effect on that ultrasound, which shows flow of blood back and forth, we would see absence of blood flow here in the area leading up to the ovary, and we would also probably see an ovary with massive edema because we don't have that backflow of lymphatics and venous back upwards towards the inferior vena cava and thoracic duct. So you're going to see two very distinctly different ultrasounds in these two pathologies that could be presenting with acute lower quadrant unilateral abdominal pain. So really rely on ultrasound findings and history here in order to help you guys secure this differential. So in terms of our high yield review, we talked about our follicular and theca-lutein cysts both being heavily dominated by fluid-filled structures. It's going to be granulosa cells in our follicular cysts and our theca interna cells in our theca-lutein cysts. Remember that the granulosa cells are going to be all associated with estrogen, whereas theca-lutein is going to be associated with beta-HCG. Our chocolate cysts, on the other hand, are going to be tissue that has migrated from the uterus, and it tends to be less fluid-like and more solid tissue-like, and it's classically going to be described as a brown chocolate cyst. And then we talked about what happens with ovarian cyst rupture, how we're going to get collection of fluid in the rectouterine pouch on ultrasound, and how this is exceptionally important for our differential. And then in ovarian torsion, we talked about the interesting anatomy here. It's important that you have the names of these ligaments down and which ones carry blood supply and which ones do not. And it's important to note that the edema is due to failure of backflow, whereas the ischemia is due to the compression of the arterial flow, and that this is going to be a surgical emergency in terms of our unilateral abdominal pain, and this will be identified on ultrasound as an absence of flow on Doppler, as well as an ovary with edema. So I really hope you guys enjoyed this video. I can't wait to see you guys in the next one. Bye!